acute and the duration of them. The incomplete, in 10%, they do have higher percent of coronary artery disease, but you don't have to have all it has to be fever sine qua non, but you can have 3 out of 5 criteria, or 2 plus the coronary artery changes, as described by Kobayashi, Professor Kobayashi, with the criteria. And they do have commonly reactivation of the T cell, this is called around the BCG, in these children who are usually miserable remain. The commonest complication is the myocardial infarction, which can lead to death, 2 to 4%. Okay, these are the coronary aneurysms, and that's these are previously on the echo, on the catheter, and the post-mortem for those who are not treated. And the severe Kawasaki, you can have just like hemophagocytic lymphohistiocytosis, HLH, they call it, with fever and hepatosplenomegaly and rash, like the systemic juvenile arthritis, etc. The Friedreich's Still's disease, but with high ferritin. So just like cytokine storm thing, okay, usually less than 1 year. Coronary artery aneurysm present at diagnosis sometime, especially in Kawasaki shock syndrome, 5%. Kawasaki shock syndrome, where you have sustained systolic hypotension, multi-organ dysfunction. So look like this condition now, aggressive treatment with IVIG required, anemia or thrombocytosis, and echo shows myocardial dysfunction. Okay, laboratory changes, you have lots of changes, anemia, high CRP, ESR, platelets increase later, hyponatremia, bad sign for Kobayashi, and low platelets, bad sign for Kobayashi, Kobayashi, and hypoalbuminemia. That's it's called the Kobayashi score, which has high index of coronary artery syndrome and also resistance to IVIG. It looks like a lot of things like measles, scarlet, Kawasaki, drug reaction. Scarlet fever is the commonest, but doesn't fulfill the criteria. Stevens-Johnson, the same. And toxic shock syndrome, which can be triggered by staphylococcal infection or others, toxins. Specific treatment, of course, aspirin, IVIG, and the steroids when they are the second line, and the others. Now, what's the pediatric multisystem inflammatory syndrome? Why does it look like Kawasaki? It's either the typical, as I said, which I described just a few minutes ago, or Kawasaki, corona-related Kawasaki, where they have positive, but they don't need positive COVID. They can have symptoms before that, even 10 days or so before it, or 2 weeks, all right? And they're usually healthy. The average age is usually higher than the Kawasaki. Still need very high temperature, not necessarily 5 days. They still have rash and conjunctivitis and enlarged lymph glands, not always, but normal vital signs. These are all increased BNP and D-dimer, not like the classical Kawasaki, which are normal. Platelets are low, not like the classical Kawasaki, and troponin normal, because the heart is preserved, myocardium. Whereas Kawasaki multisystem inflammatory syndrome, positive IgG, that's positive IgG, not necessarily PCR. Fever, diarrhea, and vomiting, usually higher age group. Black and Asian minority, ethnicity or ethnic minority, usually male. 3/4 can be even obese or overweight, 75%. cardiac dysfunction, ECG changes, high troponin, BNP, CRP, ferritin, D-dimer, and platelets low. They need ICU, or even not only IPPV, they need even ECMO, some of them. Or those who have, like 3B, COVID-19, but corona shock, they call it, without cardiac dysfunction, preserved, but coronary dilatation, okay, because of the generalized vasodilatation and inflammatory responses. And they have moderate ARDS, just like adults. And again, high ferritin, D-dimer, troponin, PCT, procalcitonin, and IL-1 and IL-6, IL-6, leukotriene, but normal platelets. The recent US Children review in New England Journal of Medicine only a month ago, 6 weeks ago, 186 children, 26 US states, median age of multisystem inflammatory syndrome showed 8.3 medium, mainly again males, so it fits what I said. Previously healthy, yes, majority, 70% positive for SARS, whether PCR or antibodies, 88% hospitalized after 16th of April, a month after the peak. Organ systems, gastrointestinal 92%, diarrhea or vomiting, abdominal pain, cardiovascular 80%, hematology like DIC 76%, 74% mucocutaneous, 70% respiratory, and average hospitalization 7 days. 80% received ICU care, 80, 4 out of 5. 48% required vasoactive support, 20% required IPPV, 4 required ECMO, 4%, and 2% died. Immunomodulation, 72%, although less than that, they are Kawasaki-like. Glucocorticoid, half, and IRA inhibitor, 20%. So 40% developed Kawasaki-like syndrome, 8% coronary aneurysm, 2% died. High. You see, in our hospitals in Evelina, showed out of the 25 cases that coronary artery abnormalities, 8 significantly impaired ventricular function, 19 underwent echo, first echo, 8 ventricular dysfunction and dilated coronary in many. And you will see here they required HDU or PICU, including ECMO, fluid resuscitation for the shocked, 70% inotropes, and IVIG less than what the American gave. That's the initial. And the outcome, the majority of cases respond to treatment. One child had coronary artery dilatation and died, actually.
Dr. Jawad, 5 minutes?
Yes, 5 minutes, I'll finish, okay? As I said, PCR can be positive or negative. Similar condition, as I said, toxic shock, HLH, as I said, hemorrhagic shock, etc. And this is when we retrospectively looked at Kawasaki and the toxic shock, there's similarities among them. That's the US in San Diego from Jane Burns. And the staphylococcal toxic shock, also when you look at them retrospectively, look like the same. It starts 1 month after the peak of appearance of COVID in any community, UK, USA, Italy, okay? They think about suspected mechanism, timing appear to be a month behind, majority negative test, but then they become positive, suggest illness mediated by acquired immunity. So they suggest is a trigger by the virus and acquired immunity and development of a cascade of inflammatory process. So all these complexes, immune complexes, lead to all these cascade of inflammatory markers. I don't need to go through the whole pathophysiology of it. Why KD-like? Because, you know, the same genetic disease points to susceptible conditions with immunoglobulin clearance, same genes result in immune complexes, etc., etc. That's the toxic shock. That's from Jane Newberger, which what I told you about, toxic Kawasaki toxic shock syndrome. And that's her hypothesis of what can cause the toxic Kawasaki shock. So it's a cytokine. That's what initiates cytokine storm, which characterized by ARDS, hypoperfusion, renal failure, etc., etc. And that's the end of it. They usually the same miserable or shocked. That's universally miserable in Kawasaki. But we are still not very clear about the exact mechanism, and only time will tell. Thank you very much.
Thank you very much, Dr. Majid Jawad, for this interesting presentation and very formal and educatable, which is actually coming now in the COVID-19 era. Now, we'll keep, as I mentioned, we'll keep the question till the end of our presentation. And please use the column on the right, question and answer, to write your question, and we'll try to answer them in the end. The next speaker is Professor Lina Patel. And Professor Lina Patel is the professor of child health and medical education. She's a consultant pediatric endocrinologist from the Royal Manchester Children's Hospital and the Division of Medical Education and School of Medical Sciences, Faculty of Biology, Medical and Health in the University of Manchester in United Kingdom. She's also, Professor Lina Patel, she's also the founder and the director of Master's Degree in Medical Education, Faculty of Biology and Medicine and Health in the University of Manchester in United Kingdom. Professor Lina Patel will do a presentation on teaching and assessment during the COVID-19, which I think is very interesting and very important subject to talk about it, especially in the era of COVID-19. Professor Lina Patel, the floor is yours.
Thank you very much for that kind introduction, and thank you for inviting me. So I hope you can see the slides.
Excellent.
This is about how do we carry on teaching, learning, and assessing in the context of COVID. And I think the important thing to think about is what has changed, and what hasn't. Some things have changed because of the social distancing. I don't know how you are managing there in Jeddah and Saudi Arabia, but here in the UK, the general practices and hospital, it's difficult to see patients face to face. We have reduced number of patients that we are seeing electively face to face. The emergencies are still managed. And of course, the inpatients are still there, but outpatient is significantly reduced. And our university has been closed since March, really. I don't know about your universities, and all the teaching currently is being delivered online. So it would be interesting to know what is happening there. So I will start with how do we continue to teach and learn? I think simply the first thing to think about is, of course, you know, we do have face-to-face interactions, and that will continue, but obviously not to the same extent. And what you have to think about is what you normally do as a teacher to facilitate learning when you are teaching face-to-face, and then combine that with online methods, such as the session that we are having today. I don't know how you think of it, you know, if you are asked to, if you're not used to delivering teaching online, and if you're asked to deliver teaching online, what are your instant thoughts? What are your instant feelings? You may want to think about that. Some of you may be very good at it. Some of you may feel nervous. I have to confess, when I was first asked, I thought, oh no, I feel lost. I don't think I can do it. The technology overwhelms me. How on earth are we going to do this? But, you know, there are ways. So it's the combination of face-to-face online, which gives us the blended teaching and learning. And that's what we have to move towards now. So I'm not going to go too much into detail about the face-to-face because you are all experienced. Just the fact that you are doctors and clinicians, you will be teaching every single day, and you will be doing that through your daily practice. So when we think of online, there's two broad categories, synchronous and asynchronous. So synchronous is a bit like what we have today, this meeting. It is live, real time, online, but all of you are connected at the same time. We are all present at the same time. It can be challenging to timetable for students and trainees. There can be problems with Wi-Fi connectivity, especially if you have got students all around the world and in some remote places. Like in the UK, if you were in the middle of Scotland, where our train recently derailed and they had no Wi-Fi connectivity and phone connectivity. Time zones, if you are around the world. Some students and trainees may have difficulties, for example, if they've got hearing impairment. And of course, you know, as the tutor, you have to multitask. It's a bit more challenging multitasking with the technology, as well as looking at all your students on the screen on the side. Asynchronous is where the online session is recorded in advance and then delivered to the students, and they can be anywhere in the world. They can learn at their own pace, at their own convenience. They can repeat as many times as they want to, and it gives the students more flexibility, and also you as a tutor, it gives more flexibility. So ideally, online teaching should be a combination of these two. And the recommendation are that the synchronous should be about 1 to 2 hours for a total teaching time of about 20 hours. So there should be more asynchronous teaching, more time for students to learn by themselves and self-directed learning with some support from the tutors, but not a huge amount. But what the little that you do provide is real quality time that you give to the students. And then even this 1 to 2 hours, it should be broken down into smaller chunks. So I think this meeting has been very well organized. None of the lectures are very long. Dr. Jawad session was about 25 minutes. I have 20 minutes. Dr. Sawal will be similar time. So it's important not to have the synchronous session too long, because it is tiring for the attendees and tiring for, especially if it's a single tutor, it's tiring for them to manage. So I'd like you to just think about what enables learning, because when we are thinking of, okay, you know, what is it that you want to deliver online, it's worth thinking about what enables learning. So if I had to ask you to prioritize 3 things, what would you immediately think of? So I hope what you would think of is motivating students, ensuring that you are promoting active learning and the social interactions, because whatever you include in your session, it needs to be interesting, it needs to be what the students need to learn. If you've embedded feedback and self-assessment, it helps students build their confidence. And this learning should be fun, shouldn't it? And then it should be active learning. So not just passively sitting, listening, observing. There should be activities built into the session. So activities before, during the session, as well as afterwards. You might give a handout to read beforehand. You might include an audio or a video, some case studies, ask the students to reflect and then post their answers, include quiz, a polling. There are various ways of introducing activity into an online teaching session. And also through the activities, ensure that there are social interactions, because that's what we enjoy, isn't it? In the face-to-face small group learning, we enjoy the discussions we have with each other. As Dr. Jawad said at the beginning, it would have been nice to be there in person, but at least we are able to see each other face to face, even online. And having some interactions with each other does make a difference. So what do you and the students need for this online? Well, the technology, you need IT, you know, people like Mr. Rami to help. You need the platforms and the software and a list of readily available resources, time to plan and prepare. So that's why it's important to not have the synchronous teaching too long, because actually you need a lot of time to prepare. For a 1-hour session, you probably need about 4 hours to really prepare a good session with activities and interactions. The technology and resources, I hope that within your setting, you have got lots of people like Mr. Rami and other people who support you. At our university, we have an excellent team, and they guide us with online resources, videos, tutorials. There's also a long list that our university has produced of free materials which are available to include. There are videos, case studies, images, lots and lots of material available online that you can use with your online teaching. So for example, this interactive clinical pharmacology site, it's free, and you can see the whole list of things that you can use during your session. I'm not going to read all these out, but you know, there's a big menu, and this is all interactive. Then this is another free site, and it's got case studies. For example, this one is a case of mistaken identity. It's about ethics and genetics. So do use the resources that are available. Of course, you know, you may make your own learning resources, but there are also lots readily available. So just to briefly summarize, how do we continue to teach and learn? Well, face-to-face doesn't stop. We still work as doctors, and we are still doing some face-to-face clinical activity. So we will continue that. And then you combine that with online, which gives blended. And it's about adapting what you normally do as a teacher with online methods and get the support of the IT experts and those who are expert in e-learning. So I will now move on to how do we continue to assess. So this is going to be challenging. I don't know how many students you have, but in our medical school, for example, we have in each year 450 students. So that's 2,500 students in the whole medical school. And OSCEs, you know, how are we going to organize that? Virtually impossible, isn't it, with COVID? So how do we do it? The real world of medicine, we're still practicing medicine, aren't we? Except the ward rounds, you probably don't have so many doctors on a ward round. You might have fewer, the consultant and maybe 1 or 2 trainees. In simulation sessions, again, you might have fewer people. In theater, the same thing I think goes on, not much change in theater, except you might not have many observers. What we do have is we still can have one-to-one sessions with students and trainees. And I think that is the strength now, that whatever we do, we are going to do it, give more quality to the time we spend with students. It's going to be brief, but it's going to be quality time. And then there is, Dr. Sawal is going to talk about clinical practice remotely, and our trainees and students are going to have to learn that. So if you think of Miller's model of competence, that's what we assess. You know, as a clinician, you need to know stuff, you need to know how to do things, you need to be able to show how you perform a clinical examination, perform an operation, and you need to be able to do it. You need to carry out a consultation and manage a patient. And we have different assessments, but COVID doesn't allow us to do some of these. So how are we going to do them? So unfortunately, the DAS was already a workplace-based assessment, and now even the shows how has to be a workplace-based performance assessment. So if we think of competencies again as knowledge and thinking processes, the attitudes, and then the doing things, the knowledge is probably going to be computerized tests, and these are going to be work-based assessments. So I'm not going to go into the details of written assessment methods, but we have 2 major formats: stimulus format, the response format, and then there's a hybrid. In the Royal College of Pediatrics and Child Health Mrcpch and DCH exams, it is a stimulus format. They are not open-ended, but in many undergraduate exams, there are open-ended questions, and I don't know what sort you use. But these are going to have to be computerized if you have many students, but if you have a small number, you may be able to organize them with the physical distancing. OSCEs. So what do we have in OSCEs? Whether it's your undergraduate OSCEs or whether it's a DCH exam or the membership exam, the Mrcpch clinical exam, we have all these different stations, don't we? History taking clinical examination, undergraduates, we might have bedside tests, there might be practical procedures, interpretation, and then clinical reasoning, management planning, giving information, and a case presentation. So what can we do now in an OSCE with the physical distancing and especially keeping pediatric patients safe? What do you think? What do you think is feasible, and what do you think is no longer feasible? History taking is going to be feasible, but challenging. If we are going to have it remote, getting patients there can be difficult. So it's probably going to be more with role players. Clinical examination is impossible in an OSCE. We cannot have real children, and we can't have role players as children. So the only way we are going to assess clinical examination skills is from the workplace-based assessments. Similarly, bedside tests and practical procedures is going to be workplace-based assessments. These components can still be done remotely. So the Mrcpch exam, we are all working. We have a working group at the moment on delivering a remote exam. You might have heard of it. And it's going to be computer-based exam with role players. And we cannot have real children, unfortunately. But doctors do have to be assessed on real children, and that will be in the workplace. So the workplace-based assessments are currently being modified so that the trainees still learn the essential clinical skills that are required with real patients, and they will be assessed on the wards and in the clinics in the real world. So the resources for OSCE in the context of COVID, we don't have these because of social distancing, but we do have these resources, and these allow us to deliver a modified remote OSCE exam. So to summarize this part, how do we continue to assess? These are not too different, except you may be delivering them through computerized tests if you have lots and lots of students. The shows how, which we would have done with short cases, long cases, OSCEs, is no longer possible. We can get, for example, for physical examination skills, we can ask a trainee to describe how they would examine a child, but it's not the same as showing how, is it? For example, if you ask me to describe how to do an appendicectomy, I can describe it to you perfectly, but I am not a surgeon. I have never done an appendicectomy, and I would not be able to show you how to do an appendicectomy, and I would not be able to do it, and I would not be safe at doing it either. So if your child had an appendicitis, I don't think you would want me as the surgeon. So knowing how to do it is not enough. We do need to assess shows how and does how. And the only way COVID permits us to do that is through performance assessments in the workplace, which have to be made more robust. So my key messages for teaching and learning are, don't be daunted by it. You are all excellent teachers. Apply and adapt your teaching skills. Remember the three most important things of a good tutor, which you all already are. Motivate the students, ensure active learning, and nurture interactions, and seek expert support for what we feel we're not good at, or we are treading on unfamiliar territory. Get expert support. For the assessments, workplace-based learning still continues. We mustn't forget that. We still have face-to-face interactions, and that is where some of the important learning and assessments are going to happen, the two top parts of Miller's pyramid. Remote OSCEs have their limitations. We can only assess knows how and show some shows how. So they might be able to show us on a dummy, for example, but that's not good enough, is it? And then written exams might be computer tests. Thank you.
Thank you very much, Dr. Lina Batel. And I think this is very important issue about teaching and assessment during the COVID-19. I think, as you mentioned, it's not only in UK, but also we are facing this problem in Kingdom of Saudi Arabia, and I'm sure it's also worldwide. So thank you for illustrating on this issue, which is important for students, residents, and interns. By the way, we have now in Saudi Arabia 28 governmental medical school and another maybe 4 or 5 private medical schools plus programs to tell you how big the issue is about teaching and assessing all these groups and all these students and residents. Now, as I mentioned earlier, we will keep the question till the end. Please have your question ready, and we will move to the last speaker in our program here, and that is Dr. Muhammad Sawal. Dr. Muhammad is a consultant pediatrician in neurology and neurodisability at Birmingham Medical School. He is also the consultant in Royal Wolverhampton Hospital in the United Kingdom. He is a senior examiner in the Royal College, and he is also particularly the lead for the West Midlands in UK. He is a senior clinical lecturer in Birmingham Medical School in United Kingdom. Dr. Muhammad Sawal will spend 25 minutes on adaptation of pediatric services during the COVID-19, which is also another important and subject, especially in the era of the coronavirus nowadays. Dr. Muhammad Sawal, please.
Thank you very much, Professor Abdulaziz, for such a kind introduction, and thank you very much for inviting me to give a talk on this prestigious conference. Thank you very much, Dr. Professor Abdul Moimin and Professor Saad. As I said, my first slide is COVID virtualism. You may not find this word in the dictionary because I just invented it, because we have got two lives now. One, the life before the COVID, and the life after the COVID-19 infections. And our first two speakers very well explained to you how we have changed in this time. The spectrum of illnesses changed, the teaching, training, and assessment has changed. And I just want to go through with you what we have done in the last about 4 months in our setting over here, and in our setting over here, and probably maybe you're going to get some point out of it. You see, we need to live with this virus for a very long time, I'm afraid. It was a sudden drop. We were not expecting that. We were having our normal life. We were waking up, having breakfast, going to the hospital, and we were not even fully prepared for these particular conditions, and in such an enormous, big way that affects our life. And when it's happened so suddenly that it's whole of our lives get disturbed, and we become very anxious, careful, and you sometimes been very anxious on our workplace, which we used to go every day. I just want to share some of my experience with you. And with that anxiety and anxiousness, it brings us loads of responsibility to look after not only these sick children, but also talk to the families. I want to tell you one thing. There was no transitions about our pre-COVID life and a post-COVID life. It dropped on us, and suddenly, and we have to live with it. We need to adopt our life to the new world, to the new changes, and get on with it, these situations. I mean, I used to go to the hospital wearing my bow tie, my half sleeves, and everything. But that's how it looks like to me. I mean, this look like I came from some other part of the world, you know. I mean, wearing my mask, my uniform change, my face shield coming up, and I mean, I can understand how difficult to see children, interact with them, interact with the families by wearing all these things on the top of your face. So big change of just approaching a child. they may get scared looking at you at all. They don't want to see you in this situation. So that's the first change we have adopted it. Okay. So what are the problems in the last 4 or 5 months? I mean, we were not as prepared as we should be about as far as our personal protective equipment is concerned. And what happened in our hospital, which probably happened the same way in other part of the country, and maybe same at your workplaces, that all our junior staff has been taken away from us, because the problem is the COVID-19 affect the adult population more than the children, and we are very lucky in that situation. But the most important the thing was our outpatient services stopped altogether. There was no face-to-face contact with them at all. And inpatients was really overstretched. And I'm sure the same situation was in Saudi Arabia. We are all being risk assessed, and all those doctors and the junior staff who are at high risk of getting that infection will be sent home, and they have been working from home. So those who are on the hospital have to give for extra mile, really have to work more, a little bit more, further looking after these desperate in these desperate hours, and for the children and the families. Life change in a big way in these situations. So I just want to tell you, I mean, it's more or less same, I think, in Saudi Arabia and in NHS, that in acute admissions, we divide the ward into the red zone and the green zones. And the children who have been suspected to have a COVID will go to the red zones. We look after by the specific staff. These children who have been less suspected go to the green zone. But eventually, whoever comes to the hospital, we will be suspecting the child has got COVID unless proved otherwise. And still, our practice is, whoever the inpatient, we all swab them. And the result we are getting within the 8 hours or maximum within the first 24 hours of the COVID-19 test. So how to communicate in this situation with the parents? I mean, you know, we are wearing all the masks and the face shielding. The parents have to talk to the nursing staff. The parents have to talk to the doctors. So we actually give them like a small walkie-talkies, so they talk from their room to us at all. So minimize the face social contact at all altogether. And we are very lucky that our pediatric population has not been hit as hard as the adult populations, and on the peak of these viruses, we haven't got many patients, and just after the peak, we get more patients like atypical presentation of Kawasaki, which has already been mentioned. Okay, but the common symptoms the children used to admitted to the hospital, we were always thinking that it may well linked to the COVID-19 infection, like diarrhea. How many children you see every day with diarrheal illnesses? So the suspicious of having this infection was quite raised during this COVID time. So it needs a lot of working together. It needs a lot of coordination between the hospital, between the different regional of the hospitals, and it needs to a lot of talking to the parents. Parents are very scared. They don't want to come to the hospital. The admission rate has gone down. And that was really very worrying time for the parents, doctors who are looking after them. And as mentioned, luckily we haven't got much mortality and morbidity, and there's not much fatality in my center in the children's. So they've been looked after very well. So virtualism comes into place. Now, there's no face-to-face contact. And all our clinical outpatient goes to the virtual clinical outpatients. They are the telephone clinics. Now, or the video consultations. We have got a system put it in by our IT department very quickly, so we can do the video consultations and looking the families and looking the child at the home situations. Okay, virtual clinics, there are some advantages. We usually ring them, and most of the time we find the parents at home. So we can talk to them, we chat with them, and if there are any questions, we answer the question. If they need any prescription, we can post them any prescriptions. So virtual clinics were in place all the time. And the important stuff in virtual clinic was that our attendance was almost 100%. So we get all the children at time. So what we do is we, in one day in advance, we inform all the children, all the families that the doctor will going to call you such and such time slots, so they can be get ready for the consultation. And we give, we have this consultation with them over the telephones or over the videos. Sometimes we don't find them at home. They have been, I mean, we have got different experience. Sometimes they don't stay at home. They'll be shopping at the shopping center, or they're driving the car. They ask us, do you want us to stop the car? I said, we said, yes, please do stop the car. And we chat around the child. But it's the clinic all went virtual. It's a daunting experience. As I said, as like a teaching. You're not seeing the child. You're not examining the child. You're just relying on the description of the parents about a child. You are managing, you're treating. So it's absolute different experience. So I mean, and this experience, we are not trained to it. It just comes to us all of a sudden. But so far it's worked very well. So we haven't started face-to-face yet, but I'll tell you when we're going to start again. This is very important. Things happen in the last 4 months when the COVID-19 was the peak in England, that all the children who have got some chronic illnesses, either the chronic chest problem, muscular dystrophy, immunodeficiency, immunosuppressant medication. There's a long list which is available on Mrcpch website. These children, we did shielding. That means that they be staying at home. And only the parents are going out for certain shopping and everything, but most of the time the children stay at home. Really socially deprivation. It can cause loads of anxiety, anxiousness, and the children were really upset. Some of them in children who have got neurodisability, they have got less mobility at home. These were the disadvantages. But the good thing is, and I'm very pleased that none of my child who've been looking after with muscular dystrophy, who are or even on home ventilators, none of them got the COVID-19 infection. So shieldings work very well for us. And I'm sure at your center or in your in Saudi Arabia, you may have done some sort of system in place that the children who are at a very high risk should be protected more compared to the other children, so that they will not going to get infections there. And we are at our center, we are very successful in that. About 400 children for which I sent the shielding letters. I'm very pleased that none of them got the COVID-19 infection. So shielding was very useful in that particular time. So Zoom come into play. We never know Zooms before at all. And the team, which is the Microsoft, apps. But the Zoom is coming into place, and all the meeting all of a sudden become Zooms. So we never see each other. We are just Zooming. That like I'm talking to about 390, 350, 70 or 80 participants sitting here in my at my home, all across the other part of the world. So it's a technology, and ITs play an important part in that things. And I'm really surprised in all the meetings, in either the local meetings, the attendance have increased from 30% to 100%, because in those meetings, people do not want to go there because the issue of parking, leaving your workplace, your time, your effort. So you are sitting in your own office or in your own place, and then you participate in the Zoom meetings. And some of our colleagues were participate in those meetings from home. So it's a big flexibility that means Zooming and teaming around these meetings during the COVID-19 situations. Now, one thing we used to do a lot in England is team around child meeting, which is the multi-professional meetings about the complex problems about a child, in which professionals from different disciplinaries comes together and discuss about those child. And we introduced obviously Zoom in that. And all the professionals took part in those Zoom meetings, and the attendance of these meetings has really improved. So the clinic went into the virtual clinic, and the meeting went into the Zoom meetings or the team meetings, team meeting. And the advantage is attendance has improved, and participants, all the participants take part in that. And the other thing is our clinical governance meeting, which used to take place every twice a week, and our departmental meetings. These are also meetings to avoid the face-to-face contact. All these meetings are on the Zoom, and this has improved again. Lot of attendance, they improve attendance, and obviously the outcome of the meeting was excellent. Now, virtualism, you're not going to find this word in dictionary, because as I said, I just invented this word, is a part of COVID-19. The virtual clinics, obviously, the no face-to-face contact has got advantages. You are not doing face-to-face. The disadvantages, I'll come back and tell you in a bit. Virtual meetings, so you are there, not there in the same area, maybe from home, from the hospital, and the virtual assessment, which Professor Alina has told you, we do different sort of assessment virtually. And the virtual consultation with the parents, and also now the thing is you can do the virtual consultation with other specialist centers across the regions. For example, in Saudi Arabia, if you're in Riyadh or Jeddah, you do the virtual consultation about a patient and discussion, and that's become much more easier. Obviously now, as we discussed, teaching and assessment also going to the virtual, and a lot of webinar. And working from home, working from home is a different concept. We medics are not very used to working from home at all. We are the people who just wake up in the morning, get ready, go to the hospital, get really busy till 7 o'clock in the evening and come back. We are not very used to working at home, and this is a big shift in the last about 4 months, that some of my colleagues and some of the people who are at the risk assessed to get the COVID-19 infection, they've been working from home, and that means they're doing all the clinic virtually from home. What we are missing? We are missing the social contacts. There's no social element. I wish I would have been there in front of the 390 people and giving you this talk, rather than sitting in front of the computer at my home and I'm talking to the computer. There's no contact. There's no face-to-face contact. The social element is gone. Okay, examination is very difficult, because we are the pediatrician are very used to examining children, and it's when we do the virtual clinic, the thing you are missing, you cannot examine the child. Even you do the video consultation, you can see how the child is walking, running, jumping, hopping in the house, but you have got no facility to how to examine the child. I mean, as I said, I like to come to the hospital, and some parents want to come to the hospital to get them to have seen, to talk to the parents. That's they are missing. As I show you my whole PPE, when I'm seeing the child, I have my face mask and face covering and my uniform, and sometimes I can't breathe in those sort of uniform. It's very difficult for me to do these things. No one see me, whether I'm smiling, I'm angry, what I'm doing. So it is a difficult task. The other thing is, my home is home. I don't want to make it my office. I mean, that's my personal opinion. And maybe some of you maybe agree with me. Okay, when you come at home, it's your own environment and your own home. If you want to make it your office, that's fair enough. So for medic, we want to go out and we want to socialize with them. So these are the things we are missing a lot. But look, it's in the last 4 months, we have gone through a lot, and we shared among each other a lot of things. But one thing I want to tell you, the sun is rising, and I'm sure we will go to meet again and have more social contact with us. So in the end, I was going to tell you, virtualism comes all together, not only the virtual clinics, but the virtual teaching and assessment and the all sort of meetings and all the conferences has gone to the virtual. But in a couple of months' time, we are starting what we call is the hybrid clinics, and that there will be some face-to-face consultation and some virtual clinics will be coming up. And thank you.
Thank you very much, Dr. Muhammad, for this interesting presentation. And I think with this, we come to the end of our scientific program. We will go now to the question and answers. There is many questions come from the attendees about, is there attendance certificate for this meeting? And the answer is yes. We will send attendance certificate for attendees. Definitely, we have their email, so it will be emailed to them from Saudi Pediatric Association through the secretary within 2 weeks' time. So if you didn't receive anything by 2 weeks, please communicate with us or with through even through. But last time we sent it to all of the attendees. CM hours due to changes of in the Saudi Council from Momaris to another new link. We couldn't get it this time, but there will be a certificate. Questions here about first question to Dr. Just move this here. Okay, we have question to Dr. Majid, Jawad.
Why am I denied photograph? I was trying to show my photograph video. I'm denied. I keep persistently denied. Is it they don't like your face, my face, or what?
Well, I can see Dr. Muhammad, I can see Professor Lina.
Switch on your video, Majid. Switch on your.
Rami can probably put us back. Rami and Mustafa can. Dr. Majid Jawad.
It doesn't matter. I can answer without face, but it would be nice to.
We insist, Majid. We insist to see your face. You know.
Honestly, I don't mind to thin my eyebrows if you like.
Okay. So the question, Majid, while we are getting the video again, the question I will read it. This is from Musa Al-Ahmari. Question to Dr. Majid: Can it be safe to use hydroxychloroquine with BIMS with cardiac dysfunction? This is the question.
Well, I'm afraid when there's no, I did say earlier, well, although I didn't go through the details for the sake of the time, those actually, it's been very much demonstrated that many who had long QT, when they are given hydroxychloroquine and azithromycin, especially combination of this hydroxychloroquine and azithromycin to children in Italy, in Bermondsey, okay, and elsewhere, but it has no effect anyway. By the way, regardless of this, I am against using it. So the short answer is no. Okay.
I quite agree. The short answer is no. We shouldn't be using hydroxychloroquine.
We shouldn't use it.
Okay, so thank you very much. The next question is probably we can answer by any of our speakers, and it's when I am using the mask BABR mask, how to examine the child in the hospital. I can't hear well. I can't put my stethoscope also. So probably.
Can I answer this? Because I think this is PP, one thing I must want to stress, the two things you should need to do. Majid, we can see you now. That's good.
Now we can see you, yes.
Okay, two things. Whenever you're going to see in the hospital, your objects are now post-COVID life is two. One, your safety is so important. And the second, the safety of your child. Your safety is very important. Many frontline doctors have been infected with COVID-19 and have very detrimental effects. So your safety is important. So you need to make sure you're wearing the appropriate PPE, which is protective equipment. So face mask, yes, you need to wear the face mask. I mean, using the, it is difficult, and even the hot environment is more difficult. If you're wearing the glasses, it make it worse. But I strongly advise you should be wearing a mask. If it's not aerosols, the aerosols, you need to wear the FP3 mask, which is more harder to wear. And you all should have a fit assessment to wear the FP3 mask that can fit on your face. And if you have got beard, and it makes sure that it fit properly, seal the nose and the mouth, so you can, and the best way to find it out, your glasses will not going to get foggy if you're wearing FP3 mask. So fit test is fine. So yes, I mean, you need to adopt to it. This is a new way of examination. You need to adopt, you need to use your stethoscope. You need to do the examination. You have seen my shield, mask, and eye examining the child with both these things. And this is important. Your safety is utmost important.
Thank you, Dr. Muhammad. Another question about Kawasaki disease with concomitant COVID-19 infection. How the mortality differs from the classical Kawasaki disease? Dr.
In a
Jawad.
classical Kawasaki disease, whether it's even during the COVID-19 era, when it is a classic, it remains the same. Some precautions as far as management is concerned in terms of now the aspirin dose is being lowered, recommended to be started as a lower dose because of the antiprostaglandin effect. But the rest are all the same. And with regard to the mortality or morbidity, the same, providing you follow the guidelines, whether American Heart Association guidance, that's you tend to follow the North American thing, or we are as British, our own Royal College of Pediatric and Child Health, or BCCCA guidelines. But if it is COVID-19 related Kawasaki-like, which with a cascade of dysfunctions, myocardial dysfunctions, and other things, I'm afraid the mortality or morbidity is higher. Okay.
In the same line, Dr. Majid, the question about anticoagulation for BIMS with or without COVID.
Well, as you know,
for anticoagulation.
Yeah. Well, as you know, when we have the severe, the shock type, TSS-like and the others, or the Kawasaki-like shock syndrome or whatever, there is a place for anticoagulation, definitely. I didn't go through the details of this because this is very much an ICU remit, if you like. There's a definite risk of microvascular dysfunction and microvascular thrombosis as a result of hyperinflammation. Okay, and definitely, yes, they use anticoagulation, but note, in a normal ordinary clinic or an outpatient, or in a simple, straightforward Kawasaki case where we use only antiplatelets as aspirin.
Okay, thank you, Dr. Majid. A question to Professor Lina Batel. Professor Batel, in the educational and in the medical education and in the curriculum for the residents, R1, R2, R3, R4, there is simulation session in most of the curriculum. The question we have here is for teaching the resident in the simulation session, which is part of the curriculum, like showing them how to do bone marrow aspiration, intubation, lumbar puncture, IVs. And this is in the curriculum every 1 to 2 months. How we can do that, particularly taking in account that even if we're talking about the Manican, Manican is available in some big centers in big city, but small cities where they have medical school or residency program, they have to come to these big cities to do these courses or short courses, even if we take the precautions. But you know, moving now in the COVID and in the era of coronavirus, it's a challenge. How we can address this problem, or how we can overcome this problem, or should we change the curriculum? This is the question here.
So you definitely have to make some modifications, because you cannot deliver the simulation. If you, I don't know how many students or trainees do you have in a session at one time. You know, if you have more than, depending on the room size, you have got to maintain the social distancing, and you cannot physically, if the room size doesn't allow the physical capacity, you are going to have to modify, maybe have more sessions but with fewer students. So it's going to require reorganization. They have to do some pre-reading beforehand, and then in the session, for the shorter time, the practical aspect is what they learn, because you know you're going to have to reorganize in such a way. So for example, you know, if it's normally 3-hour session and part of it is some information that you are sharing with them, then it's some practical work, and then it's a discussion, you might have to reorganize it so that the information giving session is separate. The practical aspect is actually done there with the role player, mannequin, dummy, whatever you are using. And then the discussion is in a separate room. So you're going to have to practically work out. We are as I said, for our medical students, we have 450 students in a year. So we are still going to deliver some of the practical teaching, but we have to reorganize it so that the groups are smaller. We normally would have had 12 to 15 students, but now we will only have 3 or 4 students.
Thank you very much, Dr. Lina. I think we move now to another question here. This is probably directed regarding the Kawasaki again. Are you using high-dose aspirin in covoid-associated Kawasaki, or is there a risk for medical students? Maybe this is another question. So let's answer the first question about using high-dose aspirin and covoid-associated Kawasaki.
As I said earlier, the advice now, our recommendation, is to use a lower dose because of the antiprostaglandin effect, and which tend to interfere with the process of coagulation, if you like. So they use it just an antiplatelet, which is sufficient at a lower dose than the earlier 130 milligram to 50 milligram per kg, if you know what I mean. But so it's a lower dose we use now.
Sure. Maybe this is directed to Dr. Patel and to Dr. Muhammad Sawal. Anyone can answer, if you can answer this question. For medical students, are we cheating them out of a real education, or maybe changing them from real education? And we will graduate students who know medicine in theory, but cannot online education and very low census for inpatients. So the question here, it's an open question. What will be the outcome of this online and also virtual clinics or online clinics with inpatient?
Okay, I can start. We had a numerous meeting in Birmingham Medical School about this to find it out. Lina is obviously in Manchester working with the medical school. We are finding out the ways how to train and teach medical students in the world of virtualism, where everything goes virtual. We're finding different ways. Small group teaching is still going on. It will go to head. The student has to see patients, and there's no question about this. I mean, we cannot take them away from the clinical aspects of the thing. Is that they have to go to the ward, like all of us. They are junior doctors. They will going to be doctors of a future. We cannot train them without seeing children. So they have to go and see children's. So, but the problem is they go to see the children's, not about 7 to 8 the students together to see one child, maybe one student to one child, but that they need to be trained to how to wear the protective equipments. Like they should be wearing masks, we should be wearing the shielding. So I mean, and then they go and talk to the patients and take the history, do the examination like any other junior doctor will going to do. That aspect we cannot take away from the students at all. On the other hand, obviously, simulations, distance learning, webinars and lectures, they will going to take place. But I must say, students need to see children and they should.
Yeah. So a doctor needs knowledge. A doctor needs knowledge. They need to be able to take a history. They need to be able to examine the patient. The examination includes observation, palpation, percussion, auscultation, and they need to be able to integrate the information they gather, formulate differential diagnosis, problem list, come up with a management plan, discuss it with the patient. They still have to learn all that. You know, they cannot just learn theory. They have to be able to examine patients. So they will learn more on dummies initially and move to, so our students in the first 2 years are learning with role players and standardized patients and with dummies and mannequins. And then from year 3 onwards, but in smaller groups, they are coming to the ward and the clinic. So we do have clinics, but we have fewer clinics than we had before. Well, fewer patients in the clinics than before. So, you know, if I normally had 3 students in my clinic, now I will only have 1 student in the clinic.
I must say that the students should really need support at this time, and we should not scare them. And they need to go to see the children. They need to go see the patient. And when we come to the Jeddah has got a very good simulation center where we do the exam. I suppose that should be very effectively used to train many doctors. So simulation is very important.
Yeah. And I agree, and to insist more on the safety of our resident and our doctors. This is very important, you know, to make sure that they are safe also.
Yes.
Sure.
Actually building a big center in Jeddah, as far as I remember. There was a new whole different building for a new center, as I was
Simulation, yeah.
Yes, we have actually big centers in Jeddah and also in Riyadh and big cities. In Jeddah, for example, we have a big simulation center in National Guard Hospital and another one in the King Abdulaziz University. I'm sure maybe there is other, but those 2 are pioneer in simulation. One more question from Dr. Abdelkader Al-Hibshi. Dr. Abdelkader Al-Hibshi is a consultant hematologist in Medina. Dr. Majid, how common pediatric multi-system inflammatory syndrome in children, as we know that COVID-19 is not common in pediatric and compared to adults?
Right. Well, it's certainly, we observe the studies from Europe, from America, from UK, well, which is now out of the European thing. There has been an increase of 30-folds compared to previous incidents of Kawasaki disease. 30-folds increase, you see? So that's significant. Well, it varies between the, two, but it is definite significant increase. It is overall remain not that very common when you take it at a national level. But for example, in UK, we had 150 cases, and it's now we started to see some decline in this. They classically followed, whether in UK, in Europe, in America, a month, as I showed in the slide, a month after the appearance or the rising of the COVID in the population. So it's something happened, a virus that's triggered and escalated a cascade of immunological reactions. That's what happened. So in terms of the incidence, when you take in UK, for example, 4 to 5 per 100,000 Kawasaki, if you multiply it by 30 times, you will see the difference. The same with America, 9 per 100,000, multiplied by the times, something like that. So that's the incidence of it. But it is, we are seeing the decline of it at the moment. Whether or not we'll see another rise after a second wave, only time will tell. I don't know.
We don't want second waves, no.
Okay. Any more comment about this?
Yes, I think the very rightly Majid said that the incidence of this Kawasaki has gone down. At our center, we only suspected 2, which we sent to the another regional center. None of them required any intensive involvement, but still our suspicion should be high. So we should keep looking for the unusual symptoms, unusual presentation in children's, any rash, any common symptoms, and we need to think of and linked it to the Kawasaki as soon as possible, because as Dr. Majid mentioned in the presentation, the inflammatory markers rise very quickly. The children get unwell very quickly, very soon. So you really need to be speed up in picking up these children, and early involvement is very detrimental.
In UK, in London area, because the South Thames Retrieval Service, one of the main hubs, as you know, we had, for example, within 6 weeks to 8 weeks, 70 cases. Okay, all required intensive care. Okay.
Okay. So I think we'll move to the last question here, and this is very important question. Probably, I don't know if we have an answer at this time for it or not. And that the question is, what are the drugs that have been...
You're breaking up. You're breaking up. You're frozen.
So the question now, okay.
What's the question? Sorry. What's the question? What are the drugs you mean?
Yeah, the question is, what are the drugs that have been so far beneficial in mild and moderate COVID-19 disease in pediatric age group?
No, nothing. Mild and nothing, please. No treatment. I hear a lot of really poor practices and, and all these weird ideas and medications. Nothing. Mild and the majority, by the way, the majority of children, well, like adults indeed, have it mild and they don't need anything, actually home treatment. And in children, a lot of them asymptomatic, and those who have symptoms, they have it mild, like runny nose and mild respiratory symptoms. 10% have gastrointestinal, except when they are in the TSS group, where they have 75% gastrointestinal, vomiting, diarrhea, and abdominal pain, etc. But these mild and moderate, please, nothing, only. So you take symptoms as a clinician, whether you are an outpatient or in the hospital, the same way as a child present to you. Is it mild symptoms, just simple antipyretics and fluid, etc., or respiratory symptom, chest X-ray, although CT scan will be better, of course, in when you have respiratory distress, will high resolution give you better. Then you have to treat accordingly. But there's no specific treatment. Full stop.
Okay, Yala. I think.
Muhammad.
Sorry. I mean, I absolutely second what Dr. Mrcpch said. Two things are very important. Our suspicion of any unusual symptom in the children, you think of at this particular time, think of COVID at this time and do the testing. Okay, this is very important. So do the testing, but please, mild one, even the moderate one, do not, they need a supportive treatment. They need a treatment for the fever, IV fluids, that's a usual sick child, but do not treat them with anything. You know, the many drugs are coming up like dexamethasone, hydroxychloroquine, they do not have any roles whatsoever unless a child go to the intensive care, which is a totally different situations. So intensivists are managing the children as totally different. So for you, at your particular thing, you treat them as symptomatic, as supportive, but be very vigilant. Do all the blood tests, be very vigilant about the respiratory symptoms getting worse, be very vigilant checking the oxygen saturations, be very vigilant. If they get worse, get the help sooner. That is the message, get the help sooner rather than sitting on them or doing something else. Lina.
Okay, thank you very much. I think with these questions, we come to the end of our 90-second Pediatric Club meeting. And on behalf of Saudi Pediatric Association, I would like to thank you all, to thank our three speakers, Dr. Majid Jawad, Professor Lina Patel, and Dr. Muhammad Sawal from United Kingdom. Thank you very much for joining us in this very interesting and beneficial meeting. And a special thank to our Pediatric Club coordinator, Professor Abdul Mu'in Al-Agha, who actually the one behind selecting this subject for the topic for today. And a special thank for Saudi Pediatric Association board member, Professor Saad Al-Saadi, who actually do the welcome address introduction about Saudi Pediatric Association. Our organizer, many thanks to event troupe, many thanks to Rami Muhammad and to Mustafa, and many thanks for our audience from all over the kingdom, the Gulf, and the world. And this is we have next 93 Pediatric Club meeting will be in 5 days time. So we have a decision as a Saudi Pediatric Association to have the 100 club before, inshallah, October, November. So, and that we will all of us, we will get it, inshallah, soon. Thank you very much again. And again, the certificate will be sent to all those who send their email within 2 weeks' time. Thank you again and see you soon, inshallah.
Thank you very much. Many thanks. And lovely to see you. Hope we'll see you soon, actually.
See you soon. Thank you.
Thank you, colleagues. Thank you. Lina and Mohammed for accepting.
Arabia or inshallah in UK soon after the COVID-19 is over, and hopefully this will be inshallah soon. Thank you.
Thank you very much. Thank you.